This program is brought to you by Emory University.
Good morning, everyone. I hope everyone had a nice first week of the new year. It is my pleasure to introduce Dr. Arshed Quyyumi, who really needs no introduction. He is a tenured professor of medicine here at Emory and the director of the Emory Clinical Cardiovascular Research Institute, also known as ECRI, and has been involved in cardiovascular research for over 30 years. Dr. Quyyumi went to medical school at Guy's Hospital in London, followed by fellowship in cardiology at the National Heart Hospital in the UK, and then fellowship at Mass General. He was a senior staff physician and the director of the cath lab at the NIH for many years before moving to Atlanta. Broadly, his translational research interests are varied and many, including cardiovascular physiology, endothelial progenitor cells, ischemic syndromes, cardiovascular biomarkers, health disparities, genomics, metabolomics, you name it, Dr. Quyyumi does it all. And I tell him all the time, I'm not sure how he does it all. Today, he's going to teach us about stress and cardiovascular disease and what at Emory, we have the largest sort of data set of people who have undergone mental stress testing, and it's the largest in the world. So we're very fortunate to have Dr. Quyyumi talk to us today about stress and cardiovascular disease.
Thank you, Pooja, and Happy New Year, everyone. I think this is the first grand rounds for the year, and what better subject to talk about than about stress. But I hope you had a nice, free of stress holiday period already. So I'm going to talk about stress and cardiovascular disease and largely talk about the studies that we have been doing over the years. And many of your patients have been participants in these studies. So I'd like to thank everyone who looks after our patients because almost 1,000 of them have participated in our studies and have been under follow-up. So I'm going to summarize all of that work for you. And I know about a month or two ago, we had Rachel Lampert, who also talked on a similar subject, but I'm going to, other than introducing the whole field, leave all of the things that she said out. She concentrated on largely electrophysiological issues. So let me move on. And so we've had funding in this area, and particularly the two highlighted grants for MIPS. And I'm going to show you those data, and MIMS is the PI for that is Viola Vaccarino. So just by way of introduction, just to remind you of what I think we heard from her talk before as well, is just a background of how stress and cardiovascular disease actually are interlinked. And have been since the first description. This is Heberden's description of angina, which we have been told is one of the earliest description of a syndrome associated with myocardial ischemia, where he describes, exercise-induced, cold-induced chest pain and calls it angina. But in the same paragraph that describes this, he also says that it is increased by disturbance of the mind. And this had gotten lost a little bit, with interpretation and progression, as we have associated angina largely with exercise-induced issues, particularly because we have now institutionalized exercise-induced or stress-induced ischemia as a way of testing for obstructive coronary artery disease. There's also some data of acute coronary events being precipitated by immediate stress, full events. And these are often anecdotal reports, and there are some larger reports. But it's well accepted that acute stressful situations that are going around you, whether they are bombings or earthquakes or even a football match, can increase the rates of acute coronary syndromes in susceptible individuals. So during the 2006 World Cup match, this is football of the European kind, where Germany lost, there was a twofold increase in myocardial infarction frequency that day after. And stressful work conditions, emotional upset has also been associated with this. Receiving news of death of a loved one can more than double the risk of acute coronary syndromes, as well as of pulmonary emboli in the first 90 days. The InterHeart study, which was 50,000 people from around the world, where they had a very simple 5-question questionnaire, which assessed emotional stress and anger issues, found that those people responded to this and higher risk of a higher prevalence of psychological stress, had 2.5-fold increased risk of MI compared to control group. And this study also showed that receiving a cancer diagnosis, actually it was a different study that showed that it was associated with a 5-fold increased risk of death in a week. So we know that these acute stressful episodes that emotionally upset us do increase risk of actually cardiovascular death, not just MI. And then defibrillator studies where people have ICDs that can be interpreted for arrhythmias have shown that negative emotion has been associated with almost 5-fold increased risk of ventricular and atrial arrhythmias. And there were increased risk of ventricular arrhythmias after 9/11 attacks. So that's all understood. It's hard to act on it in an individual, but we do know that there is a real impact of stress on cardiovascular events. And one of the classical syndromes that we all know about that I won't talk about is Takotsubo, where a stressful episode can lead to this stunning of the myocardium that is thought to be due to sudden increase in catecholamine levels that cause intense vasoconstriction of the coronary microcirculation. Usually that leads to this stunned myocardium, which presents with troponemia, presents like an acute heart attack and then completely recovers weeks and months later. Now, there have been a lot of epidemiological studies that have been done by many people over the years to try to assess this link between heart disease and cardiovascular outcomes, both in the general population without risks for cardiovascular disease, as well as in people with multiple risk factors or with known cardiovascular disease. So this is the data of the general population. And so increased hazard ratios are on the right side of this dotted line. And one would consider that something that increases risk by 2-fold or above as being significant risk factor. So it was only extreme stress in childhood that was associated with future risk of cardiovascular disease, but job stress and other perceived stresses, etc., where although associated with increased risk, it was relatively modest in the general population. But when it comes to high-risk populations, or people with known cardiovascular disease, then these kinds of psychological stressful episodes or exposures were associated with much more than 2-fold increased risk of acute coronary events as well as of death. So in childhood trauma, exposure to childhood trauma is associated even in the relatively healthy population with future development of cardiovascular disease. But in the healthy adults, otherwise, stress has minimal impact. It doesn't have zero impact. But in those with coronary heart disease, stress is a strong determinant of adverse outcomes. So this is in the general population risk of stroke or coronary heart disease. Red is people exposed to stress, just a minor increase perhaps, but the risk overall is so low. But once you have people with known cardiovascular disease, then the risk of MI and death increases quite substantially in those who say they're exposed to stress. So the mechanisms of how this all works have been sort of speculated and researched upon over the years. Negative emotions, etc., are thought to increase stress, negative outlook, anxiety. All of these features are thought to act through behavioral as well as biological processes. So people who are in the state of depression or stress can smoke more, not be very active, eat poorly, medication non-compliance, etc. And then the pathophysiological changes that occur are related to how this is perceived in the central nervous system, the activation of hypothalamic pituitary axis, the autonomic dysregulation and inflammation, etc., which we'll come to in a bit more detail in a minute. Whereas on the other hand, if you have a positive psychological outlook, have a happy affect, have a sense of purpose, optimism, etc., then less likely to be smoking, more physically active, more adherent to medications, etc., even if you have disease. And this is thought to be associated with better outcomes. So the overall hope is that you can take people who perhaps are exposed to negative psychological health, convert it into more positive outlook, if that is feasible and possible. And then that would lead to improvement in behavior as well as the downstream effects and improve cardiovascular health overall. So this would be potentially the ways of dealing with this. When we come to pathophysiology of how stress leads to cardiovascular disease, then there are a lot of things that have been explored individually and in combination. For example, there is evidence of autonomic activation, of neuroendocrine activation, hemodynamic changes that occur, changes that lead to coagulation abnormalities, and other cytokine activation that occurs. And we'll approach some of these issues in a second. And somehow these are, for example, you can imagine the autonomic dysregulation can lead to increased cardiac electrical instability and expose the ischemic myocardium if there is any, or just a heart that is diseased, to electrical instability and therefore to ventricular arrhythmias and death. That these other factors can lead to myocardial ischemia and somehow lead to plaque disruption and then acute coronary syndromes or stroke. So this brings me to a series of studies that we have been undertaking over the years. I guess it's been more than 10 years, where we had obtained this funding from NHLBI in a program project grant, which really is a very large grant with 3 or 4 projects and 3 or 4 cores, or 2 or 3 cores. And this was I have to acknowledge this right up front that Viola Vaccarino is really a world leader in this field of stress physiology and cardiovascular disease, and has led the group over the many years, and she's had continuous funding in this area and others for more than 30 years from the NIH. And Doug Bremner was the other PI, a project PI, and there were a lot of other very good people as part of this. And then some of the data that I'm going to share will also be from the MIMS-2 study, which was a similar study done in post-MI population by Dr. Vaccarino's group. So this is our model of acute stress that we, if you like, inflict on our patients. The study was focused in people who had known coronary artery disease. And as I said, a lot of your patients have possibly participated in these studies, for which we are very grateful. The way this flows is that, and the idea behind this was that we wanted to know what happens to the cardiovascular system and its reactivity after exposing an individual to an acute psychological stress episode. And then secondly, to see whether how they reacted led to how well they did in the future. So we followed these people year after year and have at least 5-year follow-up on most of them now that I'm going to share you the results of. And then at that time, when we had designed this, there was some evidence that ischemia would occur during mental stress, and this would be associated with increased risk. So we wanted to show or see whether that was the case, first of all, and whether we could prove in a definitive manner in a very large group of people, whether that was the case and whether that was what was leading to increased risk due to psychological stress in people with cardiovascular disease. So the model goes like this. The patient is brought into this room, which is quiet, and they're rested for a while. And then they're given this, what we call the mental stress test, which is where they are given a scenario of a speech that they have to make for 3 minutes. And the scenario is that somebody they love has been in a nursing home, and they have been mistreated, and then you're going to talk to the owners of the nursing home and the next morning, and then you're going to tell them about this and then see and tell them how you feel about this, the fact that your loved one was mistreated. So that's really the scenario. They're given 2 minutes to prepare their speech and 3 minutes to give the speech. So it literally takes 5 minutes to do the whole thing. And at the 1 minute before the end of their speech, they're injected with radioisotope, technetium, to scan their heart to see if they've developed any flow abnormalities during the speech making. And then they're imaged afterwards, and they also have a resting image. Now, while this person is sitting there, they are confronted by at least 2 or 3 people looking like this, very serious, with their hands folded, listening to them making the speech. And there's a camera that's in front of them that they know is recording their speech, and they're not allowed to stop, just continually speak for 3 minutes. So that's really the stress that they're exposed to. And I'm going to share with you a number of results that we found over the years where this stressful episode was enacted in this way. And we go through the hemodynamic changes, the vasomotor changes, the functional changes of the vasculature that we measured non-invasively, and other biomarkers. And of course, myocardial ischemia. So this is what happens to hemodynamics when you're exposed to 3 minutes of speech making on an uncomfortable subject. The rate pressure product goes up as a result of both the systolic blood pressure going up and the diastolic blood pressure going up and the heart rate going up. The systolic blood pressure goes up by about 30%, diastolic pressure goes up. So unlike physical exercise, where diastolic pressure either remains the same or goes down, the diastolic blood pressure also goes up, and that's what causes a larger increase in rate pressure product than you might imagine. And heart rate goes up a little bit. But certainly none of this goes up as much as it does during physical exercise if you were to do the treadmill in the same individual. And then, of course, catecholamine levels go up, epinephrine goes up, norepinephrine goes up, but the way we measure in the circulation is not a good way of measuring norepinephrine changes, because if you remember that most of the norepinephrine that's released in the nerve endings is reuptaken, so you can't really measure circulating levels. So really only the epinephrine levels are reflective of the activation of the sympathetic nervous system. We also measured with a fingertip device called PAT, or pulsatile arterial tonometry, the pulsatility in the fingertips. So this is measuring, if you like, the vasodilator tone of your fingertip. And then during the mental stress, so this is the resting period, during mental stress and during recovery, and you see how this individual, for example, constricts pretty profoundly and then recovers during the recovery period. This person constricts very little, relatively speaking. So people constricted as a result of the microcirculation in the digit constricted to a certain extent, on average, about 29%. So the PAT ratio, which is the magnitude of this during mental stress versus what it is baseline, is what we calculate. So 29% on average constriction. We also measured endothelial function after, say, about an hour of having had this episode. The endothelial function goes down by almost 20-25%. Arterial stiffness goes up. So even after an hour of having been exposed to 3 minutes of this kind of speech making, there is profound effect such that your endothelium doesn't have as much nitric oxide in the brachial artery where it's measured. In a separate subset of patients who were going through cardiac catheterization, we also measured similar changes during mental stress and measured endothelial function in their coronary circulation. And these studies were done using the cardiometrics flow wire, inserted in this case in the proximal LAD, that allows us to measure the signals in terms of flow velocity at rest and during infusion of various agents. And these agents include acetylcholine, which is done as a dose response with increasing doses, which allows us to test vascular endothelial function, adenosine that allows us to study endothelium independent flow reserve, and then we perform mental stress in a similar way, but in this case, we ask them to do mental arithmetic, subtracting 7 from 999, while they were being harassed a little bit for 3 minutes. And then we repeated the endothelial function and then tested endothelium independent function using nitroprusside. And I've included pictures of people who were instrumental in performing these studies and allowing us to do this, as well as publishing the papers. So Mohammed Hamada wrote the paper. Habib and Creton were instrumental in helping us do this in the Emory and VA cath labs. So the results are as follows. The mental stress exercise increased the heart rate and blood pressure as we expected. This is the mental arithmetic. But coronary epicardial vessels constricted by around 5% and significantly so. So there is epicardial constriction overall that occurs during mental stress. Once again, if you had a normal circulation, not have people with coronary disease where the endothelium is dysfunctional, then you'd expect the epicardial vessels to dilate by about the same amount. Coronary blood flow on average didn't change, which meant that the coronary vascular resistance actually went up because the blood pressure and heart rate had gone up. So it means that unlike what you'd expect, what the coronary circulation should do if it was relatively healthy, which is to maintain coronary vascular resistance the same by allowing vasodilation to occur to the extent to which it is required because you're increasing workload for the heart, it doesn't do that. And the coronary circulation actually constricts. This is now all microcirculation. Okay, we are doing this study in an epicardial vessel that is not diseased, so there is no resistance from the epicardial vessels. It is only from the microcirculation. Now, a dramatic change that is rarely seen in the epicardial vessel. This is a person who has clearly a diseased, heavily diseased proximal LAD, undergoes mental arithmetic testing and completely shuts it off, has ischemia, and then with nitroglycerin opens up again. So these are rare. These are things that you don't often see, but can be happening naturally when people complain of chest pain during acute stressful episodes. So when we looked at people who constricted in response to mental stress, that's shown in red, versus people who dilated in response to mental stress in terms of their flow responses, then the acetylcholine response was similar. In other words, those who constricted with acetylcholine constricted with mental stress, those who dilated with acetylcholine dilated with mental stress. However, both groups had similar vasodilation to endothelium-independent agents such as nitroprusside, and flow reserve was similar in the two groups of people. In other words, there was a significant relationship between vasodilation in response to acetylcholine, meaning endothelial function. So the better the endothelial function, the better the response to mental stress. So one of the reasons, or the main reason, whereby coronary microcirculation doesn't dilate to the extent that it should during mental stress episodes is because of the degree of endothelial dysfunction that there is. And that is there because they have coronary disease and all the risk factors that are present. Now, even more important was the relationship between what was happening in the peripheral circulation, which was measured as a PAT ratio. You remember in the digit of the finger where we're measuring the microcirculation, versus what was happening in the coronary microcirculation, which is shown as a reciprocal of RPP over coronary blood flows to adjust the coronary blood flow changes to the change in RPP. And you can see this inverse relationship such that people who didn't constrict in the peripheral circulation didn't constrict in the coronary circulation, vice versa. So the coronary circulation's vasoconstriction is almost completely being reflected by what's happening in the fingertip. So if we see major constriction in the fingertip, then we can assume that they're having a similar vasoconstrictor episode within their coronary circulation as well. So one is reflecting the other. So this is the first demonstration of that during stress. We also measured, as I said, inflammatory markers. IL-6 levels go up pretty dramatically, MCP1, MMP9s, and so on. CRP actually looks like it doesn't go up, but we measured these changes 45 and 90 minutes later. If we had measured it 6 hours later, we would have seen a similar increase in CRP. Now, as I said, this was focused on myocardial ischemia, so we imaged people during while they were having their mental stress testing done and then after rest, and we found a lot of people who had ischemia. In fact, in almost 900 and plus individuals that are tested in these two studies, 16%, 1 in 6 individuals would develop myocardial ischemia during mental stress testing. In the same population, 31% had conventional stress ischemia because on the following day, they would either have treadmill or regadenoson scan in the usual way to see whether these individuals who were having mental stress ischemia were the same as individuals who were also having conventional stress ischemia or not. Remember, these are chronic stable people that were picked up from clinic in a relatively asymptomatic state. None of them had chest pain during their mental stress testing, not one. So it's usually silent. And it occurs, as we've shown already, at lower heart rate, much lower rate pressure product than during conventional stress testing, and is almost never accompanied by EKG changes. So in summary, if you look at coronary and peripheral changes with mental stress, coronaries constrict and the microcirculation, the peripheral microcirculation constricts. There's endothelial dysfunction that's longer lasting. There's increased arterial stiffness. There's a catecholamine increase. And there are a lot of inflammatory and other pathways that are activated. And myocardial ischemia can be precipitated in these people in 1 in 6 times. So these are nice studies that show you physiological and pathophysiologically what happens in this population. But then the question is, what is the long-term impact of these changes? Does the way one react change the way we, what happens prognostically in these individuals? So these are results of 5-year follow-up in people who were enrolled in MIPS and MIMS. So these are the two studies that I mentioned earlier. Remember, 16% had MSI, mental stress ischemia. Lots of events over the next cardiovascular death and MI. So we're looking at solid, hard events. 2.4-fold increased risk of death or MI if you had mental stress ischemia compared to if you didn't. In the MIPS study that was reproduced in the MIMS study where the risk was even higher. This is a post-MI population, 3.5-fold increased risk in people who had mental stress-induced ischemia compared to those who didn't. Now, would this have been reflected if we'd just done the conventional stress testing? So here's the data splitting people into those who had no ischemia in either test, those who had conventional stress-induced ischemia only, shown in the orange line, those who only had mental stress-induced ischemia, that was a minority of the population, or those who had both ischemia during mental stress as well as during conventional stress testing. So you see almost 4-fold increased risk in those people who were positive for mental stress as well as physical stress, whereas those who were just mental stress positive had 2-fold increased risk. And the least increased risk was people who only had the conventional stress positive. Now, when we looked at the other responses that I showed you earlier that were happening, the amount of vasoconstriction that was occurring in these people measured with PAT. So PAT ratio itself was also predictive of future outcomes. So those who had more vasoconstriction, which is the low PAT people, though they had 1.7-fold increased risk compared to those who had relatively normal, not as much vasoconstriction. We also found, as I said, that FMD, flow-mediated vasodilation, which is a reflection of nitric oxide in the brachial artery, that went down by about 23%. Those people in whom there was this transient endothelial dysfunction actually did worse during follow-up compared to those people, 1.7-fold increased risk in these individuals as well. People had a different rate pressure product response during the mental stress test. So here's, as you can see, prep, speaking, recovery. This increase in rate pressure product was variable. Those people who had less than median increase in rate pressure product, in other words, they could not mount the same increase in rate pressure product during the mental stress test, did worse. Again, 1.8-fold increased risk in these people compared to those who were able to mount an increase in rate pressure product. So we had these three non-invasive, one looking at the microcirculation, one looking at endothelial function, one looking at the rate pressure product change, which were all independently of each other predictive of outcomes. So we combined them together into this ratio, what we call the cardiovascular reactivity risk score. So you had one normal, 2, 3, and then each of them were looked at in quartiles. And so we created this risk score. And what it shows is that if you had a low score, meaning you had less abnormalities in these three tests, you had much better outcome than those who had a higher score, 2.2-fold increased risk. So you can grade people's risk based on their reactivity in their circulation to a single episode of mental stress. That gives us much better delineation of risk in these people who are at huge residual risk. These are people with stable coronary artery disease that are in our clinics who are maximally treated, managed, revascularized, etc., who have all of this residual risk that we don't know about that can be illustrated based on their reactivity to stressful episodes that they're undergoing presumably throughout their life on a daily basis. There were other things that were looked at, and this was done by, work was done by Amit's group, Anish Shah, who's worked on this manuscript. So these people had also Holter monitoring while they were going through mental stress, and that allowed us to study heart rate variability, the low frequency and the high frequency, et cetera, which is a reflection of our autonomic regulation, if you like, our autonomic nervous system, the intactness of the autonomic nervous system. So normally what you want is, with stress, for the heart rate variability to increase, showing that there is robustness in the system, but sometimes it doesn't, it decreases. So if you looked at individuals who had mental stress-induced heart rate variability increase versus those in which the heart rate variability decreased, this is the low frequency type of heart rate variability, huge difference in outcomes, 3-fold increased risk in these. And this is just looking at cardiovascular mortality, not MI and so on, which are not predicted by this. Among other biomarkers that we studied were regenerative markers like progenitor cells. They were also predictive. SDF1, which is in the same pathway, and I won't belabor these points because there were some biomarkers that were also predictive of outcomes. Now, as we go forwards, and these are preliminary data that we have been accumulating as part of the next grant application, but just to share with you, we have begun to do proteomics and metabolomics testing in the samples that have been taken at baseline and after stress, to ask the question whether there are other pathways, et cetera, that are activated, or there is a makeup of an individual that is susceptible to this kind of abnormality, and then it leads to worse outcomes that would allow us to develop perhaps a simple blood test that would identify people at increased risk. And there you can see the number of proteins that are obviously activated, that are associated with the high-risk reactivity profiling. And similarly, there are metabolites that change after stress 90 minutes later that are not only changing, but some of them shown in blue are associated with worse prognosis. So this is something that we would pursue in the future. So in terms of prediction, of future risk or residual risk in people with coronary disease who are otherwise stable and well managed, allowing them to have a simple mental stress test like this will show that about 1 in 6 of them develop myocardial ischemia, which is usually asymptomatic. And then there are these vascular changes that include microvascular constriction, rate pressure product change that may be insufficient, and endothelial dysfunction that occurs, and abnormal heart rate reactivity and biomarker changes that identify a group of people that are at much higher risk. Now, you might ask, well, all this cannot be done. There is no such thing. You can't order this in the clinic as of yet. Can we just ask the people and say, well, you know, how stressed are you, by using some questionnaires, and would that give us the information that we need? So these people obviously also had a lot of questionnaires done: depression questionnaire, post-traumatic stress, PTSD, anxiety, anger, hostility, and perceived stress questionnaires. This work by Pratik combine all of these different scales into what was a sort of composite score, if you like, of psychological distress. And what he found was that in men, it was not very predictive, but it was predictive in women. This is some of our early analysis, and we have now much longer follow-up and 2 data sets, so this will have to be revisited, but shows that even at least in women, assessing the risk in this using multiple scales might get us some of the information of those who are at particularly higher risk based on questions. We also found that there was a lot of heterogeneity by sex, age, race, and by social determinants. And just a quick look at this, for example, the vasoconstriction that we were studying, the microvascular changes using PAT. The response to stress was associated with 50% greater risk only in women and in the post-MI cohort, not in men, whereas endothelial dysfunction abnormalities were predictive in both. Transient endothelial dysfunction occurred more often in Black individuals compared to non-Black patients, and they also had a higher risk based on this abnormality compared to the non-Black individuals. Major adverse event rates were higher in those who had increase in IL-6 and MCP-1 in response to mental stress, but this was only seen in women and not in men. Patients with PTSD had higher rates of ischemia during mental stress. Patients with high versus low poverty neighborhood where they came from had similar hemodynamic values at rest, and lower rate pressure products increased. This is the high-risk responses during stress. So the background social determinants was a significant predictor of a high-risk reactivity. Younger women had higher IL-6 changes, for example, compared to older women and men, although everybody had an increase. And CAD severity was associated with MSI, mental stress ischemia, among men, but not among women. So these are multiple manuscripts that have already been published, but I just highlight how these things are not the same in all of us, that they are different, and they are different by individual makeup. Now, the last part I wanted to talk to you about was studies that were also part of our grant application, and studies that were performed, headed by Doug Bremner's group, where we examined the relationship of brain activation with what we were seeing in the cardiovascular system activation that I just showed you. So he was able to perform PET studies in 170 individuals. Not only did they had all the cardiac testing done using radioisotopes, et cetera, that I described during mental stress, but on one day they were invited to the PET lab and they underwent brain PET studies. These were performed using O15 water, and there were 8 PET scans done. During this, there were 2 control periods where patients were just counting or talking about nothing. And then they had the true stressful episodes where they were made to do mental arithmetic and then speech. So you see how this was done, and then each time these control periods of stress, there was a PET scan performed to look at blood flow changes in the brain. So these are areas that got activated during mental arithmetic compared to the resting periods in brains of that you see here of men and women. Similar activation, but a lot of areas, and I won't go through this, I'm not a neuroscientist, but just to show you how one can see changes in blood flow, meaning activation in these areas, because activation leads to increased blood flow in these specific areas of the brain. But I'll just focus on 1 or 2 things that to sort of summarize what we found using these studies. The activation of the rostromedial prefrontal cortex, which is shown here. This area activation is actually related to amygdala, which is thought to be a very important part that controls psychological input and then activates the hypothalamus and pituitary. So these activation in this area, those individuals who had greater activation of this area, shown here, had worse outcomes compared to those who didn't. So this is long-term prognosis in people who had differential activation in this area of the brain that is associated with psychological processing of psychological information, rostromedial prefrontal cortex. Now you'd say, well, how does this activation specifically lead to all of this downstream effects that finally kills you more often? So in this study, there was further examination of IL-6 changes and heart rate reactivity, heart rate variability changes with respect to what was happening in the brain activation. And there were some neat relationships that you see here. So for example, those individuals who had greater activation also had lower high-frequency heart rate reactivity, meaning they had higher risk, mediated perhaps through this. And then those who had higher activation of this area also had higher increases in IL-6. So greater inflammatory activation and reduced heart rate variability, suggesting autonomic dysregulation as a result of this. Now, there were other studies, other correlations made like this, other brain areas that correlated with occurrence of myocardial ischemia, even with presence of obesity or not, and as you can see here with heart rate variability, and so on. That so clearly, the brain and how it perceives and how it reacts, particularly in these crucial areas of the brain, in response to acute mental stress that we were testing, but perhaps also during chronic stress exposures that individuals are exposed to during their daily life, then leads to the kind of abnormal activation that we see that then lead to the worst prognosis. So the brain seems to be where the action is, the way we process information that's related to psychological stress, that then leads to specific ways of activation of the brain that is different amongst people. And that leads to these downstream effects that are mediated through the cardiovascular system in the way they are, and in the biomarkers, et cetera, that we are studying that reflect pathways that then affect people who have cardiovascular disease in a differential way, depending on who we are. So it's a complex system, but this is clearly how it flows. So question is, what do we do about this? How do we translate this? How do we move forwards with this? Should we be considering risk stratification of high-risk patients with mental stress rather than what we do, which is to use conventional stress testing? Is there an easier way of using perhaps psychological stress stimulus in the clinic where we would be able to measure these, maybe even these reactivity changes that allows us to dissect individuals who are at high risk based on this kind of reactivity. This is always to find people who are at additional risk than we imagine, because we think we have maximally treated people like this. Yet there are people who have residual risk that remain unidentified. So a clinic-based mental stress test for individuals with coronary artery disease or at high risk that would evaluate this cardiovascular risk reactivity score. What are the molecular signatures? Perhaps there are simple tests we can do, blood tests, that we would discover profiles that allow us to find who these individuals are who react in a certain way. And then should we not really see what's happening during daily life? Because clearly this one episode is not going to make them die, but clearly is reflecting how perhaps repeated episodes like this during daily life in these individuals who react in a certain way are leading to worse outcomes in these individuals. So how is that? How much daily life stress there is? What's the reactivity during this? So using wearable technologies, assess stress during daily life, which is doable, and then look at heart rate variability, et cetera, during that. How does maladaptive stress reactivity lead to plaque disruption? How does all of this cause you to have plaque rupture, have myocardial infarction, and die? Or is it all because of arrhythmias? So we want to study using coronary CT, advanced plaque analysis to see if this is associated with vulnerability of plaque, and are these individuals the ones who are at most at risk because they have more rapid progression of their coronary disease to acute coronary syndromes because they are suffering from increased levels of vulnerable plaque, as is reflected by the inflammatory markers, et cetera. And then further understanding the role of brain pathways, and then even thinking about intervening on the brain pathways that are activating this whole downstream process that is leading to cardiovascular progression, of course, to investigate specific therapies to deal with this, which is a great need and we have very little information on. So in order to address these things, we have amassed a group of experts. As I said, Viola is a sort of world's expert, but the group as a whole, actually, I don't think there are many other groups worldwide who have devoted so much time, effort, and actually published so much on this area as this group has. So clearly we are well positioned, and you see the cast of characters here who have come together to propose the next group of studies enveloping some of these questions that I've put out here. Because mental stress really is ubiquitous. It's there all the time. We are all affected by it, but we are all affected by it pathophysiologically in different ways. And even though clinically we obsess about food intake and or beverage intake as risk factors for cardiovascular disease in our patients, we hardly ever address the stress aspects of disease, which clearly are having an enormous impact, but is very poorly studied. And it's poorly studied partly because we have compartmentalized medicine or healthcare into subspecialties, and this falls into this sort of no man's land where we understand the cardiovascular consequences and physiology and pathophysiology, but the psychiatrists and the neuroscientists understand the brain pathways, and really it needs coming together of cardiovascular people with epidemiologists and imaging experts and bioinformaticians and psychologists and neuroscientists and psychiatrists and so on, data science people, in order to pull together this whole field so that it becomes an important part of this. But unfortunately, at least as far as our funding agencies goes, there has been lack of interest or minimal interest in supporting these things, partly because of the way this falls between the stools. As far as clinical use and our advisory boards and things are concerned, the American Heart Association, well, it was adding sleep to the Life Simple 7s and calling it Life Simple 8, have talked about psychological health as being an important contributor to cardiovascular disease and its progression, and talked about this in this review article, for example, but have not gone as far as including this in the assessment of risk. However, the European guidelines, which are always a little bit ahead, have acknowledged that stress is a target for prevention for people at high risk of cardiovascular disease or with those with established disease. These are the people who are most impacted by stress. But what we really lack is evidence-based interventions that you can treat people with if you found people who were at high risk. And there are some small studies using yoga and meditation and even walking, etc. But these results are far from conclusive, and the studies are far from definitive. And this requires investment, as I said. However, Emory, to end on a good note, Emory is blessed with a group led by Viola and her colleagues and many of us who have followed and have a small army of experts who have spent a lot of time in this field and hope to make a change. I need to acknowledge a lot of people who have allowed these studies to progress and to succeed, etc. And especially mention Nancy Murrah, who I think most of you know. Hopefully, she gets all your patients. Almost 1,000 people who've gone through these studies, multiple visits, getting scans, etc. It's not a small undertaking, and you really need to take my hat off, because she has been a sort of a real central piece of how these studies flow. And it's recognition of the fact that all of our coordinators and study nurses and technicians and are really so talented, and without them, we will not be able to conduct any of this. And of course, thank the cath lab attendings and cardiology staff, etc., who've allowed their patients to participate, and the many, many fellows, generations of fellows who have conducted these studies and have published so elegantly papers on this. Many of them are in places like JAMA and so on, and many good meetings. As I said, it takes a village from epidemiology, people's pictures you've seen, biostats, data management, the VA, CATS funds, our cardiology colleagues, cath lab, imaging, progenitor cell lab, omics, vascular lab, and regular lab people to make this happen. We've published nearly 60 papers on this, if you're interested, some nice reviews as well. And of course, we thank our funding agencies. Thank you very much for your attention. I'm done.
Great, thank you so much. A wonderful summary, and really congratulations to you and the group for this, and to get actual objective data. I have a question, and I see that Dr. Niazi has a question. I will read it to you. Do you think that some of the cardiac medications that we have our patients on exacerbate or reduce the maladaptive stress activity?
We have not been able to discern that, because we have the way these studies are done is that people are made to stop their medications the day before, so that we don't get interference from, having taken the medicines the morning of the studies. Beta blockers are stopped 2 days before, if we are able to. And so really that's how they conducted. We have not done interventional studies using drugs, etc. In some of our earlier cohorts, we had, when the cohorts were smaller, we looked at ACE inhibitors and thought that those individuals who were treated with ACE inhibitors had better reactivity compared to those who didn't. But we have not examined these issues in the larger cohort that we have now.
Okay, any other questions or comments? Go ahead and either unmute or if you raise your hand, I may not be able to see because we have a lot of participants. My screen won't allow.
Arshed, it's Peter Block. Can I ask a quick question?
Yes, go ahead.
Can you hear me?
Yes.
Good. Arshed, this is a wonderful talk, and it's been one of those areas that has been so difficult to evaluate. You get high grades for this work. The thing that strikes me about what you're showing is that much of the change that occurs with stress and all the things that you've shown ends up in the microvascular circulation and in endothelial dysfunction rather than in large vessel disease, which is essentially we as particularly interventional cardiologists, really all we think about, right? Put a stent in and everything is going to be okay. And yet you're showing clearly that the abnormalities here do not have anything to do with epicardial vessels. So, and our therapies for this brings me to the sort of so what question. Should we all do yoga? There's not very much we can do for endothelial dysfunction at this point, obviously. But your thoughts on this, I think I would welcome. Where do you think we're heading with this in terms of, yes, we can say you're going to die, but that really isn't a nice thing to be able to say to your patient without being a little bit more positive about what can be done.
Yeah, I mean this is a great question, Peter, as always. And this is our next, hurdle, if you like. This is now that we know how to identify people, we need to learn how to treat them and reduce or change the reactivity to similar stress. I think we cannot take the stress away. We need to face that. People will have stress just as part of life. The question is how we are reacting to it. How does our brain perceive it, and then how does the rest of the vasculature? So the attack, as it were, on this can be at the vascular level. So we could look at things that improve endothelial dysfunction. Now, of course, you said that nothing treats endothelial, everything treats endothelial dysfunction. Statins do, ACE inhibitors do, and all these SGLT2s and things also do. So there are ways in which we can mitigate some of the endothelial dysfunction that's fundamental to having atherosclerotic disease. So that's one. The other is to use these ways of meditation or things along those lines, mindfulness, etc., teaching people of how to handle stress that would mitigate some of this. And there are some preliminary studies that we have done that headed by Amit's group, where we have begun to look at these kinds of things and study coronary blood flow changes before and after using PET to look at microvascular changes in flow. And there is some suggestion that there is improvement with those kinds of efforts as well. So it would be a combined way of doing this, and there are vagal stimulation. There are a lot of techniques that can be employed that would be outside of the usual medication arena that we usually rely on to treat cardiovascular disease. But you're right, this is work that needs to be done and invested in.
Just a comment when Peter said, other than just telling people that they're going to die, one of the lead articles in Annals last year had to do with what physicians say to patients and how you impact weight loss. And if you take a positive approach, that is that if you do this, we have these opportunities, versus saying to somebody, oh, you're overweight and this is horrible, patients actually have much better outcomes with a positive approach. So I think we need to think about that in what we're telling patients, how we approach their disease states, and that sort of thing. And then just related to stress in our society, we have become much more disconnected, asking people about how much time they're spending on social media, how much time are they getting into polarized situation with what they're reading about. Those are some of the things that we might consider might be important, because a lot of these, there's a huge amount of stress now compared to even 5 or 6 years ago. And I would encourage people to read David Brooks' book that's out now on How to Know a Person, where he talks about all these different stressors that people are experiencing and how we relate with each other.
There's a question from Larry Spurling about benefits of exercise and whether there was any evidence for that, cardiac rehab, for example. And Larry, there are some small studies looking at benefits of exercise to mitigate stress, showing positive effects, but certainly not for this group of individuals that we're talking about. And then to study whether this reactivity, this high-risk changes that we see that are associated with worse prognosis as a sort of an intermediate measure can be improved by these individuals. So those studies need to be done. But certainly it's been shown that stress can be relieved with exercise.
Arshed, Stan Sherman. Just a quick question. Guideline-directed medical therapy has beta blockers, and there are beta blockers that are approved and not approved, for coronary disease and prognosis. And have you thought about, looking at the beta blockers and the effect they have on stress, and instead of just stopping them before the testing?
Yes. Previous to coming here, we've done some studies using beta blockers and calcium channel blockers and seeing their effects on coronary microcirculation, on coronary blood flow in people with coronary disease. And it's complicated, but in essence, beta blockers are okay to use. There's theoretical reasons to worry about beta blockers when you're talking about vasoconstriction, because they're supposed to vasoconstrict you. But actually, in response to stress, they respond you act in a way where coronary blood flow actually is not less. It may be more. And the workload is lessened because you're on beta blockers. So the net effect of being on a beta blocker is actually positive, if that's not too complicated. So it prevents the vasoconstriction that occurs in the epicardial vessels, for example, during stress.
And it may be dose dependent, right? Because maybe at lower doses, they're good. At higher doses, we don't know.
That may be so, yeah.
Okay, great. We're past 8:30. Thank you again, Dr. Quyyumi. That was an incredible presentation, as has been mentioned, and I will see everyone next week. Don't forget to get your CME credit. Remember, you have to text now or go online to the Emory CME website. Thank you.
The preceding program is copyrighted by Emory University.